This is the last lecture of your urinary system. Yeah, and after that, you have a tutorial also, right? It's about the acid-base balance today. Okay. And is it the last one, or do you have one more tutorial in the middle of the week somewhere? Yeah. Regarding the lectures, as I said, it is the last lecture. The topic is about the control of sodium and potassium ions. We are just discussing two important ions, rather the most important ions. How kidneys help in the regulation of these ions? This is the issue, which is known as the renal handling or the handling by the kidneys. Before truly going into the function of kidney, how kidneys regulate these ions, let's have a warm-up, a little discussion about these ions themselves. Now, as we know, sodium and potassium ions are the most important ions. One is having highest concentration in the extracellular fluid and the other in the intracellular fluid. Okay? These are the two important ions. Sodium, as you know, rich extracellularly. Yes. And sodium does have very important functions. I think all of us are aware of the function of sodium. Just a little brush up. How is sodium helping the body? And why do we want homeostasis of the sodium? What is the main function?
Blood pressure.
Right?
Nerve function.
Okay.
Also, secondary transports.
Alright. Okay. Well, sodium is an essential ion in the extracellular fluid, and you have to maintain the excitability of the tissues, because if you remember, sodium forms the basis of excitability because it is required for the action potential. Okay? And you know, action potential is needed essentially by the nervous system and by the muscular system. Okay? So it means for the neuromuscular excitability, you need sodium. Besides, sodium is helping in the regulation of intracellular volume and osmolality, as you're saying, that it is the main issue in the sodium-potassium pump also. Okay? It maintains the homeostasis of the cell. Besides, it has some other functions in the body. But considering the topmost functions, you just need to maintain homeostasis in a very accurate way. We'll see the functions, list of functions soon here in the presentation also. But the main idea is that excitability should be maintained and the cellular integrity should be maintained by the transport processes. So it is essentially required in the transport processes, and for the nervous system working and the muscular system working, yes, it is. Now, there are a few terms which we use for the sodium. When I say normonatremia, I'm using the word normonatremia. Okay? I'm referring to a term. What do you understand by this term? Normal levels of the sodium. Okay, and when you say normal levels of the sodium in the blood, emia means blood, yeah, you're right, thank you. What range comes in mind approximately? There may be a difference in books, but what is the average range? It's the average value, around 140, 142 is the average value. Taqriban, okay? From 2. Very good. Okay, that's a good idea. From 135 to 145 is taken as the acceptable range. Okay? Milliequivalents per liter or millimoles per liter. 135 to 145. It means you have defined the limit of the normonatremia. Now it's very easy to go to hyponatremia. If you say hyponatremia,
below 145.
Okay, it's on the other side. 135, less than 135 is hyponatremia. Okay. And for hypernatremia now it will become more than 145 is taken as hypernatremia. Okay? Well, hypernatremia has different grades, and as you go, the severity increases as you drop down. Okay? Below 125 is severe form of hypernatremia. Below 125. And if you go above 157 on the other side, starting is 145 for hypernatremia, but if you exceed 157, you label it as severe form of hypernatremia. Okay? And definitely it has bad effects on body. Changes in the excitability, fatigue, edema, and leading to seizures and coma. In both conditions it can happen. Okay, so it's bad both ways. That's why we have to maintain sodium within 135 to 145 something. This is our range of maintenance. Okay? We'll talk about potassium later, but before going to potassium, one more thing. Sodium is modular in the extracellular fluid, and sodium is also present in the urine. Okay? There is a urinary concentration of sodium which can change, which can fluctuate. It changes on the daily basis also, and it changes from one urine concentration to another urine concentration. Anyway, sodium concentration of urine less than 20 indicates hyponatremia also. Generally speaking, less than 20 millimoles per liter of urinary sodium concentration indicates that it's a low level module in the plasma. That's why low is coming in urine under average conditions like this. And if it is exceeding 40 millimoles per liter in urine, and at that time, if the plasma osmolality is low, or the urinary or the plasma sodium concentration is low, and urine has high in more than 40 millimoles per liter, then there is a mismatch between these two. And you have to think why this mismatch is there, why urine is having more and plasma is having less at that time. Okay? Urine is actually secondary to the plasma always, But in this mismatch, you have to think of a condition, and that is known as syndrome of inappropriate ADH secretion. When an excessive ADH is coming in the body, and that's causing excessive sodium excretion in the urine. Okay? Urine will contain more sodium. The water will be taken back, but more sodium is going in urine. The urine is more concentrated. So, urinary sodium concentration is also important to see the diluted urine or the concentrated urine, or to see the conditions like hyponatremia and syndrome of inappropriate ADH secretion. Okay? So not only we are talking about the plasma osmolality and the plasma sodium concentration, we are also talking about the urinary concentration, which is of significance also. Okay? Anyway, that was an introduction to sodium, because before going into the details of sodium, it was good to know about the normal levels and the deviations from the normal levels and the plasma sodium versus the urinary sodium. Okay? Now we have at least some idea about that. Are we all okay about that? Okay. Let's get started, and objectives are very simple. You have to see the role of the kidney in sodium and potassium. Yes, my dear.
Increase of sodium, increase of ADH,
Increase of sodium will promote normally an increase in ADH secretion. Okay, it's a normal factor, because whenever you have high plasma sodium, that will stimulate the release of ADH. But I am talking about a special condition, syndrome of inappropriate ADH secretion. That's coming from the tumor, okay, or excessive secretion which is under no control. If there is very high ADH due to abnormal conditions, then later it will affect the urinary osmolality, and the osmolality of the urine and the sodium concentration will go high. Okay? Few points about sodium, as we have mentioned already. We have seen the functions also. It is a part of many secretions, it is helping in the transport, it is necessary for the excitability process, and it is associated with the other ions in the acid-base balance also for some salts, but that's okay. If you are done with the excitability and transport, I think we have done the major part of the sodium. Well, yes, some calculations, some statistics about sodium. Let's have a look. Few facts are known to us about sodium, that when sodium filters in the kidney, about 65% of the sodium is reabsorbed in the proximal tubules. That we all know. Okay? Definitely, the remaining 35% out of that, major amount of sodium is coming back, and very little in terms of percentage is going in urine. Okay? Because you need sodium back. After proximal tubules have performed their function, the responsibility of other areas come now. And now you can see what is the loop of Henle doing in this regard and what is the collecting ducts doing in this regard. 25% plus 5% plus 5%, another 5%, taqreeban. Okay? So what we are talking about is that the major share of sodium reabsorbed after proximal tubules goes to the thick loop of Henle. Remember a very special pump in the thick loop of Henle, a triple transporter, 3 different substances going together. Okay? So that's a very powerful pump. And that will give you about 25% of the sodium reabsorption. Then in DCT also you have sodium chloride co-transport and the sodium reabsorption in other forms, and that will give you another 5%. And maybe the last part, determining part, is 4 to 5%. It varies according to the need, because now ADH and aldosterone are modules in that area, so they will decide about how much sodium should be reabsorbed. Anyway, major share of sodium is coming back into the plasma as you know. Okay? And a very little is going in urine. Alright, very quickly, looking at different areas, different sites where sodium is being reabsorbed. I'm sure you know it. Just have a pictorial view and look at the pictures here. From the proximal tubule, there are many different transport processes. Okay? Secondary and primary transport processes, active transports, which are reabsorbing sodium. Sodium is also passing from the tight junctions, if you remember, and it is also reabsorbed from the tight junction. So various forms of transports are used for the sodium in the proximal tubules. Sodium glucose, sodium amino acid, sodium vitamin. On the back side you have sodium potassium, and from the leaky tight junctions it's the diffusion of the sodium which is going along with the water and iron, right? You have seen it so many times. Besides, you have some counter transports also in the form of you will say sodium hydrogen counter transport, okay? And others also. Sodium is also associated with some organic salts and other substances. Anyway, sodium is giving maximum contribution in transport along with other substances, Whether it's a co-transport or a counter-transport, well, sodium is number one right now. Okay? You can see some more mechanisms here, what we have listed. So, from the front door and from the back door. Front door means the luminal surface and the back door means the basolateral surface. Well, there are many availabilities for sodium. There is no problem. Thick ascending loop of Henle, you know about it. We just discussed the most important issue is one thing, and that's the triple transporter. Alright? A very powerful one. That's giving you about 25% of the sodium. Okay? And besides, if you remember, now you are done with the pharmacology also, any diuretics issue, you have done it. Okay? And you saw the most powerful diuretics called the high ceiling diuretics, because they have the maximum therapeutic efficacy. Maximum efficacy. They have the highest ceiling among the efficacies of different diuretics, and these are the best diuretics for exerting the diuretic effect. This is about the loop diuretics. Furosemide, bumetanide, ethacrynic acid, and so many others really. It's a big group, and a very, very powerful group. Number one. That's inhibiting this pump. And if you inhibit this pump, you are losing how much? About it's about 25% you are working on. Imagine, okay, it's a big share, rather biggest share. You can't touch 65%, but you can modify this 25%, and that will give you very strong diuresis. Okay, sodium is in the later part also being reabsorbed along with the chloride and there are other sodium channels also modules here. And this is a good strategy to block these channels and the transporters also in the distal tubules really. You can have late distal tubule in connecting areas where you have many other diuretics working, not as powerful as the loop diuretics, but they are good. They are very good really. And you can see the growths. Okay? Some sodium channel blockers like amiloride and trientolene are there. These agents are also blocking some special channels of the sodium, and they are inhibiting the sodium reabsorption from the distal tubules and the connecting path. Okay? Besides, you have some very special diuretics which are against the action of aldosterone. Do you remember that? Aldosterone inhibitors or aldosterone antagonists. They are competing for the receptors of the aldosterone in the kidney. Receptors are intracytoplasmic. Do you agree with me or no? The receptors for the aldosterone are not on the membrane. They are inside the cytoplasm. Aldosterone is a steroid, if you remember.
Yes.
Steroid receptors are modular in cytoplasm. Anyway, there is a competition going on between these diuretic agents and the aldosterone. And whoever is more will win the war. So if you give these diuretics, they will compete with aldosterone. They will inhibit the action of the aldosterone, and they will inhibit all those effects which are produced by the aldosterone. So these are called competitive aldosterone antagonists. Okay? The most famous and the classical one, the prototype is spironolactone, if you remember. Okay? And there are others as well which are belonging to the same class. Anyway, so if you block the aldosterone, you are basically blocking the activity of the sodium-potassium pump on the back side and the sodium channels on the front side. You are blocking the two major modes for the sodium, and that's why your sodium reabsorption will decrease and a good deal of diuresis is there. At the same time, you are saving the potassium for the body, if you remember. Okay? That's why this specific group is potassium sparing diuretic. Okay? Alright, very quickly. It's a short story really. We are looking at the sodium homeostasis or sodium balance in the body. The normal rule says that under average conditions, when there is no abnormality, the homeostasis is maintained by, or the steady state is maintained by, the intake and the output, which are balancing each other. If the intake is approximately balancing the output, then you will not have any excess or deficiency of sodium in the body. Okay? So you have to see the intake first of all, and we have for the intake, there are different mechanisms for it. For intake, there is a center, we believe, in the brain, in the hypothalamic area, and that center is salt appetite center, and that center stimulation leads to craving of the salt. When we are short of salt, when we are short of sodium, that center is activated by hyponatremia or low sodium concentration, and that will give us a psychological desire to look for the sodium, and we'll go for the salty foods automatically. We'll try and get the salty foods by our choice. Okay? So the ishtaha for the salty foods increases really, and it's a real appetite at that time. Okay? This is for the salt. Okay? Also, if there is low volume, when there is a low volume in the body, hypovolemia in the extracellular fluid, that will also stimulate the brain through special receptors, which are the pressure sensing receptors, and they have the connection with this salt appetite center also. So at the same time, what you will have by different mechanisms of hyponatremia and hypovolemia, you can stimulate the salt appetite in the body, and the person will go for the salt, and the salt intake improves. This mechanism is also modular in the animals who don't know about what is salt really, but when they are deficient of the salt, they automatically go and search for those areas where salt is there. They go and lick the rocks and the salty areas, and automatically they get the sodium.
It's called pica, right?
Humans, that's very special. The pica is an abnormal craving, in a strange craving in special conditions. States, it's a psychological state really, especially happening in pregnancy.
Right.
In women basically. They go for the ice, okay? The crushed ice, they have an ishtiha automatically, and they feel very good, and they improve their function, the mental function, and they feel satisfied. They go for some kind of a clay or some other things. They have an abnormal desire to eat that clay.
Isn't that because of minerals?
Well, I don't know, we have not come to the exact reason of that pica, but this is very, very commonly seen all over the world.
Even animals get it. They start looking at shovels and fences and whatever.
It seems abnormal, but they
They
can
get the
sense
minerals and they're fine. They stop doing it.
Yeah, there must be some logic behind it.
There has to be.
Yeah. All right. Well, the output of the sodium, it is mainly regulated by the kidney. The sodium is also being lost from feces, but it's a very little amount. It's not a big amount. Sweat also contains sodium, but that's a major issue. The major handling again is coming from the kidney. Okay. All right. Just an issue that there are different types of receptors. One interesting point only, just to recall: low pressure receptors and high pressure receptors. These you have done these receptors in CVS. Back in CVS, there are some receptors called low pressure receptors and some receptors known as high pressure receptors in different parts of circulation. They are present in different blood vessels. Now, why are low pressure receptors called low pressure and why are high pressure called high pressure? Give me an idea, please.
Those since low pressure and those since high pressure.
It's very simple, okay? It's very, very simple. Low pressure receptors are called low pressure. Look at this picture. Look at the areas which are mentioned here in the picture and then give me an answer. Low pressure receptors, look at the areas. High pressure receptors, look at the areas and then answer the question.
Oh, well, that's because these are the parts of the circulation where the pressure is normally the lowest.
Yes, okay. The idea is not that they are controlling the low pressure or the high pressure. The idea is that where are they present, in which part of the circulation. Some parts of circulation are normally regarded as low pressure areas because the pressure is naturally low. You require a low pressure. In some areas you have a normal high pressure. These are high pressure areas. Now the receptors are named according to the areas. If they are present in the high pressure areas of circulation, they are high pressure receptors. If they are present in the low pressure areas, they are low pressure receptors. Okay? Now, these receptors are concerned with the regulation of the sodium. Okay? Yeah.
Before we leave, I'm noticing something. There's mechanical receptors and water receptors and then volume receptors and pressure receptors.
Okay, I'm sure you know the meaning of the word mechanoreceptors and the baroreceptors. Right?
Yes.
Okay. Mechanoreceptors, well, are the stress receptors. But when you say low pressure mechanoreceptors, you're talking about the volume detecting receptors rather than the pressure detecting receptors. They check the volume in the low pressure area. Low pressure areas are the veins. Do you agree with me?
Right.
And veins have a good volume already. When the volume increases in the veins, there is stretching of the veins, and that is sensed by the veins that now the volume is increased, the capacitance of the veins changes. And in that condition, they will send the signals to the brain and other areas of the body in order to regulate that volume. And in doing so, they also change the sodium excretion from the body.
Right.
Okay? So this is about the volume receptors because they are detecting volume primarily.
Well, then it's not pressure receptor, it's just.
Well,
Right. Pressure
and
is for the
volume is related to the pressure also, but we are looking for the primary factor first. Okay? So if primarily something is detecting the volume, we regard it as the volume one. It is also affecting the pressure because the pressure is also high at that time in circulation when the volume is increasing under normal conditions. Okay? High pressure barometers, they are especially meant for detecting the pressure, not the volume. Volume is not the issue here. The pressure in the system is issue, and right now we are talking about the arterial pressure. It's not the venous pressure we are looking at, the arterial pressure. Okay? So that's why we use the term high pressure baroreceptors for the arteries and low pressure volume receptors for the veins. Venous circulation and the right atrium. Right atrium itself is a part of the venous system. Consider that. It has the lowest pressure, zero pressure on the average basis. Isn't it? Okay?
All right. Yeah.
Now, very quickly, there are different factors which are concerned with the sodium excretion in the form of reabsorption or in the form of letting it go in urine. These factors, right from the filtration rate up to the hormones which are there, different hormones and the process of filtration and some other factors in between, all are helping in contributing in the sodium regulation. Let's have a quick look at these factors. They're very easy and very interesting. You know about these factors, you just have to look at the pictures. Look at them. There is a term, I don't know if I discussed this term, and maybe I did not discuss this term before. It was there in one of the presentations, but I did not discuss this term. It was a glomerulotubular balance. Okay? It's a very special balance between the glomerulus and the tubules. There is an agreement between the glomerular filtration and the tubules that if the glomerular filtration increases, the tubules will adjust themselves accordingly and they will modify their functions also. If it is increasing, the tubules will maintain the same percentage of reabsorption of most of the substances. Alright? Sodium, potassium, etc., especially the sodium. Okay? And that balance is neatly maintained. This is called glomerulotubular balance. For example, if I double the GFR, it will not cause like 130% reabsorption of the sodium at that time. It will still maintain 65% out of the share which is coming. So the same percentage is maintained by the tubules. That's a wonderful balance done by the tubules in order to maintain everything normal in the body. Okay? This is called the glomerulotubular balance. Likewise, if you decrease the glomerular filtration rate to half, okay, the half of the fluid which is filtered will still show 65% reabsorption of the sodium. Same way, okay? So things will change accordingly. Whatever is the glomerular filtration rate, you will have to maintain the sodium reabsorption, and that's glomerulotubular balance. I hope it is clear? Yes. Okay, that's quite easy. Okay? Well, the factors at the level of the peritubular capillaries are located in the back side. Okay? And if different forces are changing in these peritubular capillaries, for example, if the pressure is increasing, the capillary pressure is increasing, and the plasma colloid osmotic pressure is decreasing, these are the main forces present in the blood. They will affect the reabsorption. Do you agree with that? Yes. The reabsorption depends on the regular forces. If you increase the capillary pressure to a very high value here, what will happen to the net reabsorption which is coming? It will decrease, and that will have a back pressure on the sodium also, and the sodium will not be reabsorbed properly. Okay, that will affect the sodium, isn't it? Okay, when the water is affected, sodium is also affected at that time. Anyway, like this, if you modify these factors which are there, it will affect the sodium reabsorption. Okay. Well, the hormones, you are quite familiar with the hormones. Aldosterone is on the top of the list. Aldosterone is the hormone that you know very well about. It's a mineralocorticoid. Sodium, potassium are the main targets. Sodium reabsorption and potassium secretion. Okay? So, now you tell me a very simple and a faithful relationship between sodium and aldosterone. What do you say? If there is an increase in sodium in the plasma or ECF, what will happen to the aldosterone secretion? Alright, aldosterone will decrease because aldosterone doesn't want any more sodium to come into the body. So aldosterone will decrease itself, and by that virtue, the sodium will not be reabsorbed properly and it will go in urine. The extra sodium will go in urine, and again the sodium balance will be maintained. Very simple. So, is it the direct relationship or the inverse relationship? What do you say? It's an inverse relationship. Sodium going up and it is going down. Sodium going down and aldosterone is going up. It's quite simple. Okay? Alright. Catecholamines also have some effect for the reabsorption. Okay? Some contribution is coming from catecholamines from the proximal tubules. We don't talk about proximal tubules much when we talk about hormones, but there are certain hormones which are acting on the proximal tubules. The main area is late distal tubule till the collecting ducts for the hormones. But it does not mean that the hormones are not acting on the other parts. Hormones are acting on many parts of the tubule, Shabab. Okay? Right from the glomerulus, proximal tubules, loop of Henle is a controversy really where hormones act. Maybe some hormones are acting on the loop of Henle as well, thick loop of Henle. But after that, it's a very, very fertile area for the hormones, the distal tubules and the collecting ducts. So that's why if I choose one best area for the hormones, I will always choose the distal tubules and the collecting ducts. I will not choose the proximal tubule or the loop of Henle or the glomerulus. You know that. Okay? Anyway, so some hormones have effect for sodium reabsorption, like catecholamines and angiotensin 2 as well. Okay? It does have an effect on sodium reabsorption. Okay? Besides, you have some hormones which are promoting sodium loss. Yeah, we did not discuss one more term at the time of introduction, and that term is natriuresis. Okay? I'm sure you know the meaning of the word diuresis and natriuresis. Can anyone tell me the meaning of the word natriuresis?
Losing salt.
Yeah. Okay. Yes. Excretion of sodium in urine. Okay. If when you are promoting sodium excretion in urine, you are using the term natriuresis. Natri means natrium, and natrium is coming from sodium. Okay. So you are not talking about, when you say salts, the answer is also correct, because in the salt you basically talk about the sodium, and along with the sodium, chloride is also there. But to be very specific, when you say natriuresis, you should mention sodium. Okay? Yeah. You're right. Okay. So atrial natriuretic peptide is inhibiting the sodium reabsorption. This peptide is coming from the heart, right? Atrium. The similar peptides are released from the brain and from the muscle. They have kind of a similar role. They have some other roles as well. But these are natriuretic peptides. If they are the family of the natriuretic peptides, they have to increase the excretion of sodium. So, is it the same like aldosterone? Is it the enemy of the aldosterone? It is the antagonist or the opponent of the aldosterone. If aldosterone is reabsorbing, it is inhibiting the reabsorption or excreting sodium. Okay? There are some other, from the injured tissues and from the local areas of the tubules and the glomerulus, the prostaglandins and endothelins are released. They are local workers, basically, working locally, not coming from behind, not from outside, locally. And they also have some inhibitory effect on the sodium. Okay, it's a minor one, but they do have some inhibitory effect. Okay? You know these terms, pressure diuresis and pressure natriuresis. Okay? By virtue of the arterial pressure, if you are increasing the water and the sodium excretion, you call it pressure diuresis and pressure natriuresis. It is not done by the hormones now. It is by the mechanical force of the pressure. So pressure is increasing the GFR, and the GFR is usually not maintained at that time by the autoregulation, and that will lead to the pressure diuresis and pressure natriuresis. It is one of the mechanisms, long-term mechanisms for the blood pressure control. Pressure diuresis and pressure natriuresis. An excellent mechanism to get rid of extra volume and pressure. So that was about sodium. We talked about sodium and its functions. We talked about the terms regarding the range of sodium normally and the deviations from the range, hypo and hyper condition. We talked about natriuresis, and we did mention the urinary sodium concentration and the significance of the urinary sodium concentration in some disorders like hyponatremia and excessive ADH secretion, right? Any problem with the sodium so far? Sodium is so easy really, okay? You have just looked at the presentation and 75% of it you already know about really. You just have to warm up and revise things, okay? It's only like we are summarizing and concluding things. Because you have, mashallah, done the kidneys very well. Potassium. Concentrations are not as much as sodium in the extracellular fluid. Shabab, when I'm saying potassium, my target is to look at the homeostasis. And when you say homeostasis, you are maintaining it, first of all, in the extracellular fluid or the intracellular fluid? Extracellular fluid. You're talking about, you have to control the intracellular homeostasis, but primarily you have to check the extracellular fluid. If everything is normal, then it will balance the intracellular conditions, you know that, okay? They will match. Potassium, very low, from 3.5 to 5 millimoles per liter or milliequivalents per liter. So, this is the range. What is the term that I should use for this range from 3.5 to 5? It's normokalemia. Thank you very much. It's normokalemia. Kalium is potassium, you know that. Okay? Natrium is sodium. That was natremia. Here it's kalemia. So it's normokalemia. If you are deviating from normokalemia on either sides, going to the lower side, it will be hypo. Less than 3 is hypo. If you are exceeding 5, okay, you will start hyperkalemia. Both are bad. And yes, okay, you don't have a big margin really. If you remember sodium, from 145 when you went to 157, then I said it was severe, isn't it? When you drop down from the value of 135 to 125, then we said that it is a very bad condition of hyponatremia, severe one. But for hypokalemia, you can't have a margin of 10 milliequivalents, and then because already it is only 3.5 to 5. How much can you change? A slight change in potassium is very sensitive. Okay? It's a very sensitive issue. That's why potassium sensitivity is very high, and you have to maintain it in a very, very narrow limit. Okay? You can't really afford to have more than 5.5 all the time, otherwise the derangements will lead to the clinical abnormalities. Okay? Likewise, if you are going from 3.5 and you drop from the value of 3, then the danger can start in terms of clinical changes. Okay? Not the true danger, but the clinical abnormalities or the features of the symptoms will start. Okay? They're manifesting themselves. So that's why you can't go here and there in potassium. You have to maintain it in a very, very well. Okay? Yeah. Functions are very easy. Again, excitability is the prime function. Sodium is coupled with potassium. Potassium is coupled with sodium. Sodium and potassium are lazim or malzoom for the excitability. Okay, they have to depend on each other. In terms of the transport pumps, sodium-potassium pump will not work. Okay, sodium and the processes of the sodium channels, voltage gated channels, and the potassium channels, they control the action potential issue.
Right, and then ultimately secondary.
So that's why you give the maximum regard to sodium and potassium in the electrolytes. Okay. Of course, we are not belittling the importance of calcium ions and the other ions, but still, okay, we begin with the sodium and potassium before any other ion. Okay. Now, potassium balance also has to be maintained, and kidneys are maintaining it. And I would go first of all for, do we have a slide here? No. Yeah, look at this slide. Okay. This slide shows us again the distribution, like sodium we discussed, that different areas of the tubules are reabsorbing different percentages of the ions. Now look at potassium ions. Sodium is done. In terms of the sodium ions, it was 65%. What do you think about potassium ions here? It's almost same, 65%, almost same. Okay, so we take it as 65%, leave it. Now you go to the other area. Our interest is now in thick loop of Fenley and the distal and the collecting ducts. Okay? If you look at the thick loop of Fenley, what do you find here? Is it impressive or not?
No.
Thick loop of Fenley?
Slight increase.
Okay, 65% has been taken by proximal tubules. 35% is Baki now. Out of that 35%, we have to see, we have to manage it. Okay? How much of the share, in terms of percentage, is going now from the thick loop of Fenley? Okay? Forget about the thin loop of Fenley, very little. Thick loop of Fenley is the major issue. It's? No. Ahmed. Now look.
Oh.
Okay, because this area, okay, maybe we are not seeing that clearly, but if you forget about this, it's very close. Now look at the percentage, please.
27.
Look at 27%. It's, if you compare it with the sodium ions, what do you say?
25.
And here it is even more, isn't it? So potassium has an upper hand here in terms of reabsorption, if you see. It's almost the same, but still, it is more. Solid, Shabab? Quickly, just wrap it up, it's easy. So, if you see, thick loop of Fenley, 27% of the potassium. Now you are left with a very little amount, really. Okay, 65 plus 27, I am bad at mathematics. Can you tell me how much?
I'm bad.
Okay, I'm not asking you then. I'll ask some other person. Yeah. It's 80.
We're all bad. It's 90 something.
Oh, I'm so happy. We are equally bad.
That's why we
Okay.
chose this.
That's why we are here. No, that's not the reason, please, okay? Don't underestimate yourselves. And it's not that we are here because of bad mathematics. It may be one of the reasons.
Right.
Okay, but our prime interest is also
Really, because we're good at biology, bad at mathematics. That's why we're here.
yeah. It happens sometimes, yeah. At least for me it's true. Anyway, look at this one. It will go for more than 90%. It's 92%, I believe. Isn't it?
Yes.
92%. Isn't it? Okay. Then about 4% is distal tubules and the collecting ducts. You can see that. Okay. DCT and the collecting ducts will take a share of about 4% from that area. That goes to about how much?
96.
96%. So 96% is normally reabsorbed. How much is left, Ahmed? 4% Baki. Okay. But look at the total excretion here. This is showing you not 4%. It's 12%. What is the mystery? Secretion also. Potassium is the only ion which is secreted here. Okay? The major ion which is secreted. So 4% is coming from the failure of the reabsorption and 8% is there from the secretion. That makes a total of 12%, isn't it? Are we comfortable with this calculation that why do we have 12% on an average basis going on urine? Of course this can change according to the needs of the potassium. Maybe secretion can decrease, maybe secretion can increase. It depends on the potassium levels. I'm talking about normal average potassium intake and output. In that condition, approximately 12% is going in urine, out of which 8% is coming from secretion and 4% is coming from the failure of the reabsorption, simply, okay, from the tubular fluid. Okay. There are different mechanisms for the potassium reabsorption also, just like sodium, you know that. Where is the SAR? Here. The other day, he asked me a very good question about the hydrogen potassium pump in the kidneys. Well, it is still a controversy going on because we don't mention it in our discussions, okay? And that was a very nice and stimulating discussion which we had. I said that I'll check it and then I'll let you know about that. Because according to my knowledge, in humans, the role of this, it is there now. It is there, module. We have discovered hydrogen potassium pump. It is mainly present in the GIT, if you remember, for hydrogen ion secretion. It's the HCl secretion. Okay? But this pump is also present here in the kidney, in the collecting ducts here. And if this pump is there, what is the exact function of this pump? We are not sure about it. It has some role in the potassium homeostasis, and it has some role in the acid-base balance in acidosis and alkalosis regarding the secretion of hydrogen ions, please. Okay? Anyway, this hydrogen potassium pump is present in animals, and we have studied in animals. In humans, we are still working on this pump, but now we have started mentioning this pump in our studies. After 2010 and so, we have started mentioning it. Okay? So we'll see this pump also, inshallah, in the pictures. You know the triple transporter in the thick glucose family. For the proximal tubules, it was easy. Potassium is absorbed by different mechanisms. Now you are in the area of the collecting ducts here, principal cells. You can see potassium is being reabsorbed. This is the pump I was talking about, hydrogen potassium pump, which we usually did not mention in our discussion. Okay? This is present. Look at the luminal surface and potassium hydrogen pump. Okay? And this is an ATPase pump. This is meant for the secretion of hydrogen also. Before that, we believe that hydrogen is secreted in the kidneys by two processes, if you remember. Have you done the acid-base balance with Dr. Mustafa or this? Are you done with it? I'm not sure if you have mentioned this pump with that one, hydrogen potassium. Have you discussed this one? With? Doctor? Okay, what's name? Dr. Husni was this. So did he discuss this pump, hydrogen potassium pump?
Hydrogen pump.
Hydrogen pump, okay? Now please, look Shabab, I'll take only a few minutes to finish, please. Okay? Go to hydrogen, please. Just have a recap. Hydrogen ion secretion. It's an active process, it's not a passive process, number one. Okay? If it's an active process, then you have to think of two different processes. Primary active transport and the secondary active transport. In the primary active transport, number one secretion is coming from integrated cells, and that is the hydrogen pump. Single hydrogen pump, ATP based pump, and that's secreting. Can you see that pump here? Hydrogen pump, directly secreting the hydrogen ions into the tubular lumen. Okay? This is primary active transport. Now we are adding one more pump for the hydrogen secretion, the primary active pump, and that's potassium, in the primary. Okay? Look at this one. Ahmed, look at this one. The Jaleel one we are mentioning here. Hydrogen potassium pump. So now, for the primary active transport of hydrogen, you will mention two things. Awal, primary hydrogen pump, okay, single pump, and the hydrogen potassium ATPase pump. Both are present on the luminal surface, and both are secreting hydrogen ions. Obviously, the main one is primary hydrogen pump, but this is also a contributor. Okay. Now, go for the secondary hydrogen transport, secondary active transport. That is the sodium hydrogen counter transport. Okay. So, for the hydrogen, now there are three transports available. Two primary active transports and one secondary active transport responsible for the total secretion or handling of the hydrogen ions. Alright, Shara? Alright. Okay. Lastly, only very quickly, let's have a look at the factors which are influencing the potassium reabsorption. Again, it's a recap of your previous discussions. It's very simple. It will take only a few minutes.
Someone really wants to talk to you.
Alright. Now please look. different factors. Last few slides, Shabab, I need you. I need all of you. Okay? Very few slides only. Sodium intake, potassium intake, hormones like aldosterone, hydrogen ions are affecting, and diuretics definitely. Diuretics not as a normal mechanism, but when the patients receive diuretics, they have an effect. Okay? So leave diuretics and take upper four factors for the normal fluctuations in the body. Okay? One by one, really. Increase sodium. When you increase the sodium intake, or when you have high sodium in the body, think positively. That will definitely cause increased sodium load coming in the kidney. Okay? Increased sodium load will stimulate the sodium-potassium pump also, which is located. If there is activation of sodium-potassium pump by the increased sodium load, what will happen? Increased sodium reabsorption here and increased potassium secretion. Okay? So you are promoting potassium, okay, by this one. Alright? Potassium secretion is increased by increased sodium load. Give me the indirect mechanism for the potassium secretion by the sodium. Direct one is whenever sodium is more, sodium will stimulate the sodium-potassium pump, and sodium-potassium pump will simply cause sodium reabsorption and it will promote the potassium secretion. Okay, this is one thing. Secondarily, aldosterone, hormonal. When sodium is high, automatically it will lower down. Okay? So if you lower down the aldosterone, what will happen?
No, increase the absorption of potassium.
If there is increased sodium,
Right.
what does this increased sodium do to the aldosterone?
It will lower its level.
It will lower the level of aldosterone.
And the function of aldosterone is to increase the reabsorption of water, chloride ions, and sodium ions.
Okay.
And decrease the excretion of potassium and hydrogen.
But what is the effect coming on the potassium? I am asking that.
Well,
The indirect effect coming on potassium. Increase secretion or not increase in secretion?
Not increase secretion.
Okay. So it means these two mechanisms are counterbalancing each other. Otherwise, if they go in the same direction, that will promote a shadid loss of potassium and it cause drastic conditions. Anyway, this balance is maintained and still it goes in the favor of potassium secretion. Okay? By the sodium excess or the sodium low. It is coming like this. Now you go for the increased potassium intake. If you increase the potassium intake, first of all, what will happen to the potassium levels? Increase. If the potassium levels increase, what will happen to aldosterone?
It depends on sodium.
Yeah. Increase. Increase. If aldosterone increases, then what will happen? It will promote or it will inhibit the potassium secretion. It will promote and increase.
Yes.
Increase or decrease, simple. Increase aldosterone. Increase plus. Okay? Alright. So it means for potassium intake, you are actually looking at the aldosterone mechanism. For the increased sodium intake, you are looking for the direct sodium mechanism, which is then indirectly affecting the potassium. Alright? Okay. Yeah. Decreased sodium intake. Yeah. Yeah. Okay. Now, from this discussion, Jawab, give me 1 point, please, all of you. From this discussion, sodium and potassium we are talking about, and we are talking about potassium ions. For aldosterone secretion, which one has a major effect, potassium or sodium? Potassium is the major controller of the aldosterone secretion. So, potassium changes will affect the aldosterone secretion much more than the sodium changes. Okay, sodium is also related with the aldosterone, high sodium, low aldosterone, but this effect is not as powerful as increased potassium and increased aldosterone, or decreased potassium and decreased aldosterone. So if you compare the sensitivity of the two systems, sodium and potassium systems, Which one will you prefer for the aldosterone? Sodium or potassium? Definitely potassium. Potassium is number one for that one. Really. Okay. In ions, potassium is the major one for the aldosterone stimulation. Please. Direct relationship. Increase, increase. Decrease, decrease. Khalas, that's it. Okay. That's easy. You have done it. Okay. We have discussed all these things. No problem. And we are done actually. That's what I'm saying. It was the last thing. So, Shabab, I think this discussion is not difficult at all. It's all conclusion of the previous knowledge that you have. Okay? Just have a quick look and you will do it inshallah. If you have any question in mind, kindly ask. You are most welcome and thanks a lot for staying.